Another video, no face popping up today, but that's all right. You get to hear this wonderful voice. But in this video, we're going to be talking about communications and documentation. A pretty dry subject, but very, very important, as we'll talk about. So make sure you follow along and rewatch if you have any questions. So when we talk about communication and documentation, we're talking about working particularly with other healthcare providers. All right. And the kind of the basis of this video is we're going to go through three parts, right? Talking about with patients and about patients and their history and whatever they call us for that day that we're going to go there and see. We're going to talk about also talking with dispatch and how that information comes from there. And then we're going to talk about when we go to the hospital, the emergency department, or wherever we're going to bring that patient. We're going to talk about speaking with those other healthcare providers there. We'll kind of go step by step, and then we'll talk about documentation, which will probably be the bulk of this lesson. But, when we talk about medical information, if we remember back from our legal chapters, right, medical information it's a privileged communication, and we want to protect the patient's information, especially because of HIPAA and patient privacy laws. And just general decency too, right? We don't want to be sharing any information with someone that should not be aware of the information or needs to know, and we need to make sure that we only tell certain people certain things. So again, maintaining that patient privacy, and again with HIPAA, right? We're talking about the actual medical records too, right? The electronic billing and whatnot. All that is to be controlled. So not only are we talking about communicating with people. And not verbally or orally, right? Talking about a patient and revealing their information, but even with our records too, right? We need to make sure as we talk about our documentation here that that's kept confidential, both in storage and what we do with it afterwards, whether we get a printout of it or have a paper copy of a patient care report we'll talk about in a minute. We need to make sure all that documentation is stored properly so that no one else can access it. And that's really important. So just keep that in mind. And no matter where you're working, there's going to be procedures for how to protect that information as well. But generally under lock and key, or with a lot of online stuff that we do now, password protected and whatnot. So let's talk a little bit about oral communication, right? When we're talking with other medical providers, and I think the best, the first step here when we get any information we're talking about a patient or a situation, right? It comes from dispatch here, and we can see a dispatcher talking to someone who's on the phone with 911 and relaying information. So, that's going to be our first source of information when we talk about our scene size up, right? When it comes from the dispatcher. And we'll use that to, start our call, start our patient assessment, see what's going on. And it goes two ways, right? We need to let our dispatch know if we need other things or other materials or what we have more than maybe what they found out originally. And another acronym here, because we all love acronyms, right? But SAILOR. So sex, age, and incident, right? Which would also be like a chief complaint, location of them, and then again, any equipment needed that you might not have on your ambulance or whatever you're responding with, and then any additional resources. So do you need extra manpower? Do you need a police department or security, or do you need an ALS ambulance for a life-threatening emergency? That's basically what we get, right? So, for example, a lot of that will come in a dispatch tone. Fire alarms dispatching whatever ambulance, we'll say Harvard, right? For a 59-year-old male, that's the first two, complaining of chest pain. All right. And they might tell us, patient is on the second floor, or how to get entry into a building or a place. If maybe now not a resident with location, whether it's like an outdoor wilderness thing, maybe they're on a certain trail, maybe it's on a roadway, and giving some information, especially as they get better information to let us know about it. A lot of times dispatch will also let us know based on the 911 call if we might need any extra equipment. So for example, if someone is injured in a body of water, right, they might dispatch the fire department with water rescue capabilities. At the same time, if we show up and it turns out we need that, we need to let them know as well. And then again, that kind of falls under the resources as well. Another thing with your equipment too is based on the chief complaint, right? You should think about what equipment should I bring inside. If someone's having chest pain, difficulty breathing, well, I want to make sure I bring my oxygen equipment, my AED, those things that would be pertinent to that type of call inside. All right. So that's from dispatch, right? And a lot of that information too, as we start to do our patient assessment and talk from our patient. But our next step here in communicating is as we get to the hospital or emergency room, or if you hand off to another agency, right? Like you can see this ski patroller here is handing off to this EMT. Or we might, you might be in a situation where your ambulance is out and you're at the scene as a first responder. You need to give a patient handoff report to a mutual aid ambulance that's coming to get that patient. So conveying or communicating with that next level of care is really, really important. And, we don't want to take forever to give a handoff report. We want to be concise, but we also want to make sure that, they understand everything that's going on. And unfortunately, it happens all the time where, you might have a patient for 20 minutes, 25 minutes by the time you get there, extricate them from the house, drive to the hospital. And you've asked this patient, 10 times now about their past medical history, and they don't tell you anything. And then as soon as they get to the hospital, they might tell the nurse or the doctor something that you asked them 3 times and they didn't know or they don't remember, and then all of a sudden they remember. So it happens, but we want to give a good, concise report, but make sure we kind of tell the whole picture here. That's what our handoff report is going to be. And we'll get some specifics here in a minute, but, what's their condition, what's their treatment, and what anything else they might need too. Particularly in EMS, right? I didn't put any pictures of it here, but we do what's called a CMED patch or a hospital radio report. Basically, when we're on our way to the hospital to let them know what we're coming in with. This way they're prepared. And a lot of times if it's what we call a priority 3 or a non-life-threatening emergency, they'll just say, see you when you get here. But if we're coming in with a really serious patient, a trauma alert, a stroke alert, someone who's had real difficulty breathing, or maybe a cardiac arrest, we want to let them know so that they can have all the staff ready, have a big room ready for us too. And that's kind of a whole nother training on giving those radio reports. But let's look at, now we get to the hospital here, and we're going to give our report on our patient to the emergency room staff, or again to another agency that might be taking our patient. And I love this Google picture here because almost never, there's a few times where a doc might meet you outside, but very rarely do the doctors meet you outside as you're coming out of the ambulance. That's a Grey's Anatomy thing. But when we give our handoff report, obviously, demographics, and a lot of times the registration tech will take that separate from the nurse, but their name, age, their address, and whatnot, so that they can see if they've ever been to that hospital or facility before. But we want our nurses and doctors to know their name, their age, chief complaint, nature of the illness or mechanism of injury. So, what's going on with that chest pain? How did it start? Or how did they get hurt when they fell or were in an accident or whatnot? Basically, anything we found on assessment. And that's our pertinent negatives and positives. So, for example, if I have my chest pain patient here, like we've been talking about, they definitely have crushing chest pain, but I'm going to ask them, do you have any history of diabetes or CHF or any of those? Those would be pertinent negatives if they say, no, I don't have diabetes. No, I'm not having difficulty breathing. We want to make sure that we let the ED know all the treatments we've given. So if we've given any medications, if we've done any interventions like CPAP, or if they're on oxygen, or, if we've bandaged any wounds and stopped any bleeding, any of the treatments that we'll do for any sets of anything. And we want to know, not only treatments we did, but how did they respond to those treatments? So did it help them improve? Did it make them worse? Hopefully not. Is anything helping here? Hopefully giving them some oxygen if they're having difficulty breathing is going to get their vital signs up. We want to give them the current vital signs, but we want to let them know their trends too, right? Were they tachycardic, fast heart rate at first, and now they've kind of settled back down into a normal range? Are they hypertensive, hypotensive? What's their oxygen saturation levels? Just make sure they know what the vitals have been for the last 20 minutes. Because again, they're going to take vitals when they get into the hospital, but they're not going to know what happened before. And that's what's so important about EMS is we see a lot of things that the nurses and doctors in the emergency room won't. Okay. So again, this should take, about a minute to give a handoff report. A lot of times they might ask questions about, especially with how things happen, because that's where we come in. That's our specialty here, is seeing, the vehicle after a motor vehicle accident, or, understanding what they were doing or what the scene looked like and different things for different illness complaints and whatnot. So, but again, about a minute, depends. And again, as we come in here, a lot of this you kind of go through the motions and you first see as you start to ride on an ambulance, but transferring the patient over to the hospital bed, you might have to help with some interventions there. You might have to help do things especially if you're running a CPR or code. So, it's an all team effort there between EMS and the emergency room staff. Okay. So after a call, right? So we talked with dispatch, we talked with the patient, we talked with other providers, we talked with the hospital staff for our handoff. When we're all done, right? That's it. We're done. Go home. Yes, except we need to document what happened. All right. And we do this using what we call a PCR, right? Patient care reports. And it's written documentation of what happened with our patient. And you got to remember, right? Every call we go on gets a PCR. So even if we get canceled or if we get a patient refusal, right, we need to fill out a PCR to document that it happened. All right. They kind of have two goals here, right, or two purposes. The first one is that they're usually part of the patient's permanent medical record. So it goes in their chart, right? We send a copy of our PCR to the hospital, and it's there. And this way, if a week from now and a patient's in ICU and the docs want to review, so how did this first start? They can pull up our PCR and see what we found on scene and what we did and what they complained about. All right. And then we can also, our PCRs are important for QA/QI, quality improvement reasons, as well as documenting different trends and data. And, you got to remember, we talk all the time in medicine, not just emergency medicine, but in all medicine, that, we are a scientific field, right? Everything we do is based on data. So PCRs provide a lot of data for over the years and different illnesses and injuries we might see. So that's one part of it. The second part is that they are legal records. So if something comes up and someone files a lawsuit, or maybe there's a malpractice issue, whatever it is, we need to document what happens, right? Because if you have to go to court years later to testify about something, if you run accidents all the time and are responding to numerous 911 calls, it's pretty easy to start to forget, some of the calls you might be on and mix things up. So you need to document every call as if your life depends on it, because it could, right? It could be you on the witness stand there, or something that might come up, and not that you screwed up, right? But there could be issues from your call, and you want to remember everything that happened. So just remember, if it isn't documented, it didn't happen. Okay. So that's really, really important. We're going to talk about specifically how to do that in a minute, a couple methods. And with the PCRs, and I would say almost most are what we call ePCRs, or electronic PCRs. But they basically have two parts. They have many, many pre-filled input fields. So, from everything from nature of illness to your scene size up to the mechanism of injury to if there's a car accident, what parts of the car were damaged, all different things that we could fill in, different things for vital signs. That basically you put in what you had. That takes up most of the PCR, but then probably what I would say is the most important part is the narrative. And that's where you write about what happened. And I say that's the most important because, for depending on what ePCR or paper PCR program you use, the pre-filled inputs do fine. They get a lot of the quantitative data, but sometimes it may not actually describe things that happened on a call, or there might be something that, it doesn't really clearly fit between one or two boxes. And that's where the narrative comes in, right? That's our quantitative. That's where I always think about it as painting a picture of exactly what happened and what you did and how the whole call went down. Because again, if years later, you're back in court or things come up about this, you want to be able to paint such a good picture that you can, boom, be right back in it and living it again. There's no questions as to what you saw. So that's why that narrative is really, really important. So there's a bunch of different ways to write narratives and different methods. I have two here, and we'll do a little bit more about one, which is the one that my service generally uses, and I like because it's a good way to do it. But the first one here is called SOAP. And I think you see this a lot in charting in doctors' offices, maybe the hospital and whatnot. It's a little more open-ended, and you can write things, but subjective, objective, assessment, and plan. So the subjective, symptoms, information the patient describes, chief complaint, HPI, which is history of present illness, past medical history. That's the subjective. That's coming from them. The objective is things that we can see, right? The signs, the quantitative findings during scene size up, physical exam, vital signs. That's the stuff that anybody could look at and see there. It's not necessarily coming from the patient. Our assessment, right? So what do we find out through our assessment? And then the plan, right? What do you do? How do you treat the patient? How do you treat different things here? How did you extricate them, move them, get from one place to another? And that's SOAP, right? That's one way you could do it. The one that I like to use is another acronym, which we call D-Chart. All right, and there's another one out there that's similar. It's called Charted. I like the D-Chart though, and we'll go through the parts here, and then we'll look at an example. But essentially, this is how you would write out your whole narrative, right? First line, D, the dispatch info, especially for motor vehicle accidents, describing the scene, but even on a regular medical, right? Where did you find the patient? What information did you get from dispatch? So it kind of, again, we're painting that picture from the second the tone goes off or you get called out, what did it look like from your perspective, responding, getting there, and whatnot. Chief complaint, right? We know what that is. By the patient, what they say, what's going on, why they called today. Then we have history, all right, and that includes the HPI, present illness, any interventions that happened before you got there that might have happened, right? Past history from the moment we showed up. Any significant past medical history, I had a stent put in, I had leg surgery, and then other sample history that we might have would go here. All right, and then the ART assessment. So again, doing our assessment. I'm not going to read every bullet point here. You could pause the video and read through them, but things that we might find. And starting from level of responsiveness and our ABCs, even with a normal, healthy patient, that's a refusal, right? We want to write that their ABCs were intact. We want to paint that picture of everything that's going on. And again, through physical assessment, vital signs, if they're abnormal, we could say something. And then RX, right? Our treatment. So what did we do to treat the patient? And then T, our transport. So again, the T, the transport, I usually include anything that we have to do with moving the patient. So how do we find them? How do we move them? This is where we would write about refusals, if they refuse care, any ALS stuff. And generally, you don't want to comment on things that are outside your scope of practice. But if ALS asks you to assist with something that we're trained in, you could document that. But generally, this is where we'd write that ALS took over after we got to a certain point. And then you want to write the end of your narrative, right? So that they know it's there. So let's look at an example of this. So this would be our D for dispatch. 13A, that's Harvard's ambulance, was dispatched with Harvard police fire for the MVA on Air Road in front of the post office. The 13A sign of the air, confirmed response. Responded lights and sirens, I don't know what says that, without delay or misdirection. On arrival, found two vehicles, a gray Honda sedan facing the wrong direction in the post office exit, and a black dump truck off the edge of Air Road on the northbound side facing traffic. EMTs found two patients in the care of the police. This one pertains to patient one, the driver. So again, really doing a nice job of describing the dispatch and then what we saw when we first showed up. And really getting into details with the different cars and different patients. And you need to remember, you need to write a different narrative for every patient, right? We're doing a PCR for every patient, which is important. So, based on this, I would be able to forget about this and hopefully 5-6 years from now, read that description that I wrote and say, oh, I remember this now. All right, so that's D chart. Chief complaint, right? Back and neck pain, simple. History, so starting out with the HPI, right? The patient could not remember the accident, mainly asking what happened. And again, this one is for this report pertains to the driver of Honda. So I know I'd rather be in the dump truck in this crash, that's for sure. But the driver of the dump truck said he was driving south at 40 miles an hour when the patient's vehicle came right out, spun around. Patient said they were wearing their seatbelt. describe the car. The car had airbag deployment, cracked windshield, deformed dashboard. Um, EMTs were unable to obtain past medical history, allergies, meds. Again, because here the patient's confused. They don't remember anything. All right, for the assessment. So, starting with the age, getting into, how do they respond to verbal stimuli, right? They're definitely not alert and oriented because they're confused, times 4 at least, but they're oriented person place, but not to time or event. So ANO times 2, Glasgow Coma Scale 13. So again, starting out with the mental status, getting into the ABCs, right? Describing anything. So like the breathing's regular, right? Airway's patent, fine. Breathing regular but labored. Pulse is slow and irregular. Skin is pale, warm, and dry. Getting into the pertinent negatives. They denied chest pain, difficulty breathing, headache, nausea, vomiting, or any vision issues, or any tingling extremities, right? Patients unsure whether they hit their head and lost consciousness, repeatedly asking what happened. He had neck and back pain, but was unable to rate or localize the pain and describe where it was. Pain in his left shoulder, right? Kind of going through the rest of your assessment here. So when ALS showed up, oscillated lung sound reported crackles. Again, you could just say that that's something that's in our scope there, and they mentioned it to you, so we could write it down. Talking about blood sugars, vitals is noted. And that's a good assessment, right? And you could write more if you find other things as well. Okay, for our treatment, C-spine mobilization, spinal motor restriction ruled in by mechanism of injury, patient's age, unreliability. So put on a C-collar, CSMs before and after, put them on some O2 here. So again, any treatments we did here, and then general supportive care, right? Talking with the patient, make sure they're comfortable, checking with them. And then finally the T, right? So again, starting back from the beginning, where did you find the patient? How did you extricate them from the vehicle or from the house, right? If this was a medical, who helped you do it? What you used to get them out, making sure that you describe that they were secured, right? Making sure that you had stabilization throughout, moved to the stretcher, again, secured, got into the ambulance, ALS came, EMTs assisted as requested. Where did you go? And again, what happened en route? Did the patient get better, same, or worse? No change in pay scale, level of responsiveness. Then describing when you arrive, right? Which bed you went to or where you go. Basically, you give the report to the staff and by ALS, and if we gave anything, we could say that. And then just saying that you transfer that patient care and that you end the report with usually your initials and your EMT number there, as you can see. And that's a sample, an example, I should say, of using the D chart method. And that's a good narrative, right? I think you'll see a lot of times if you get into the industry and you're running, 12, 15 calls a day, you may not feel like you have the time to write that much, and that's okay. But again, you want to hit the highlights there, right? It's always better to over document and take a really good time than to do less, because you never know when a case is going to end up being pulled up and you might have to go be a witness somewhere, or there might be questions about care that was given. So really important to do that. All right. And then again, right, that's the end here, but just reminding that patient privacy, that EPCR that we write gets sent to the hospital. We're going to keep it on file in our records. And then, anything that is not locked away needs to be destroyed. We can't share that with anybody. And, if you notice here, right, there's no name of the patient in the narrative. All right. That's going to be in the PCR portion. And just one other thing I was thinking about, when you give your radio report too, not the written, but you don't want to give the patient's name over the radio, because anybody can listen to that. That's always in person or over the phone if someone were to ask. But, generally you give their name and their demographics in person, never over the radio. So just, again, protecting that patient privacy. So, all right, that was a lot there, pretty dry, but a really, really important topic for all EMS and medical professionals to understand is documentation. So again, if you want to read through that a little bit more carefully, you can pause the video in each slide and take a look, but review it. And if you have any questions, let me know, and we'll see you on the next one.